Hello everyone, hope you're all doing good. In this video, we are going to discuss about genitourinary fistulas. So, what is this genitourinary fistulas? This is nothing but an abnormal communication between the genital tract, that is nothing but the vagina, cervix or the uterus, and the urinary tract. Okay, so that will include the bladder, urethra or even the urethra. Clear? Now, let's see the classification of genitourinary fistulas. Based on the anatomy, it is classified as ureteric fistula. Okay, ureteric fistula, which can be further classified as urethrovaginal, ureterocervix or ureterouterine. Clear? And the second type is the vesical fistula, where you can have a Vesicovaginal fistula or a vesicocervical fistula or a vesico-uterine fistula. That is the connection of the bladder with either cervix, vagina or the uterus. The next type is urethral fistula, yes, which can be either urethrovaginal or urethrocervical. Clear? Now, I hope if you see this lateral anatomy picture, you will be able to understand how the communication can exist. Okay. So, it can be, imagine this is the bladder, right? So, yeah, repeating. So, this is the bladder and the ureters would be coming like this. So, any communication can exist like this. Okay, so it can be the urethrovaginal, okay, urethrovaginal, then this is the uterus, okay, uretrocervix or uterine. Clear? Right. There is also another new classification given now. It is based on the distance from the external urinary meatus, the size and extent of fibrosis, vaginal length and other special considerations. Okay. So, let us see. If we take the distance from external urethral meatus, that is the distal portion of the fistula, I will draw a scale here. Okay. So, that is 1.5, 2.5, 3.5. Okay. So, type 1 is anything more than 3.5 centimeters. Type 2 is between 2.5 to 3.5 centimeter. Type 3 is between 1.5 to 2.5 centimeters. And type 4 is anything less than that. Okay, this is type 4. Okay, so this is according to the distance of the fistula from the external urinary meatus, right? The second one depends upon the size of the fistula itself. Okay, it is divided into mild, moderate and severe. So the smaller fistula is going to be less than 1.5 centimeters and a moderate fistula is going to be between 1.5 to 3 centimeters and a big fistula is going to be more than 3 centimeters. Clear? Right. Let's also discuss about the fibrosis. Fibrosis can be none or mild, or otherwise it can be moderate and severe also. Clear? Next one is according to the vaginal length. It can be a high vaginal fistula that is present in the upper part of vagina, then a mid vaginal fistula that is present in the center part of vagina, and number 3, yes, it can be a low vaginal fistula also where it is present in the lower part of the vagina. Clear? Right. Now we have to give some special considerations also in the classification. So special considerations will include the fistulas that has arisen due to post radiation or previous repair, etc. Clear? Right. Now let's discuss about some causes of fistula. So causes of fistula include obstetric causes, okay. So the most common cause in obstetrics that is causing fistula is, yes, obstructed labor. So how obstructed labor is going to cause fistula? Actually it causes ischemic necrosis, which will be superimposed with the infection, and that will cause sloughing and lead to fistula formation. Okay. Obstetrical surgeries like destructive operations, forceps delivery, or even a cesarean section can give rise to fistula in obstetrics, right? And the second cause can be those rising due to gynecological causes that include, yes, mainly hysterectomy, and it can happen in any type of hysterectomy, say a total abdominal hysterectomy or total laparoscopic hysterectomy or a total vaginal hysterectomy as well. Clear? Right. Let's also see some of the other causes causing fistula. This include malignancy. For example, advanced CA cervix, okay, and it can also arise due to radiation or a trauma or a foreign body, especially forgotten pessary, okay, and in some of the infections also like tuberculosis, LGV, etc. Clear? Right. Now I want to summarize one important point, that is, in developing countries, Okay. The important cause is going to be obstructed labor, okay, which will lead to fistula in 90% of the cases. Whereas in developed countries, gynecological causes are the main causes for fistula, and then laparoscopic hysterectomy is the most common cause of fistula, which will be followed by your abdominal and then vaginal route to cause fistulas. Clear? Right. Now, let's see the presentation. Okay. So, presentation of fistulas. Here, the patient usually complains of, yes, continuous leakage of urine pervaginally. This will be the most common complaint, right? And when there is continuous leakage, you have to give them a probing question, like whether she has normal urination also. If that is happening, then it should be a uterovaginal fistula, okay, and only continuous leakage is there, but there is no normal urination, means that will be mostly vesicovaginal fistula. Clear? Right. Now, associated symptoms may also include, there will be emission of offensive urinary smell, then itching around the vulva can also be there. Okay. Now, in case of obstructed labor or prolonged labor, usually the symptoms will rise 4 to 7 days after delivery, because there will be ischemic necrosis and then only sloughing of that particular area, right? And in cases of operative delivery or gynecological surgeries, she will complain of leakage of urine from day 1 itself. Clear? So, obstructed or prolonged labor, the complaint will be starting only after 4 to 7 days, whereas in gynecological cases and operative delivery, the complaint will be present from day 1, because that will be very acute, okay, because the mechanism of fistula in obstructed labor is ischemic necrosis. Clear? Right. Now, let us see how we are going to diagnose this condition. So, diagnosis is mainly done by a famous test. Yes, it is done by a 3 swab test, right? Yeah. So, 3 swab test. So, what we are going to do in this test? In step 1, we are going to place 3 pieces of cotton. Okay, so 3 pieces of cotton swab or gauze, okay, that will be placed through the vagina at 3 places. Okay, the first place is upper part of vagina, second one is, yes, middle portion of vagina, and the next one is lower part near the introitus. Clear? Next one is Step 2. Okay, here you have to instill the bladder with 300 ml of diluted solution of blue or indigo carmine through a catheter. Okay. Then step 3, you have to ask the patient to do normal activity or then she can be asked to walk for 15 to 30 minutes. Okay, so these are the 3 steps of doing this 3 swab test. Okay, so first one, you are placing a cotton and then you are instilling the bladder with 300 ml of diluted solution of blue or indigo carmine, and finally you have to ask the patient to either do her normal routine activity or ask her to walk for 15 to 30 minutes. Okay, so this is how the cotton swabs will be placed. Okay, so this is how the cotton swabs will be placed. So this is the vagina. So in the upper, middle and lower portion of vagina, we are placing 3 cotton swabs, right? Okay, then how will we be interpreting this test? Okay, suppose if the lowermost dye is stained with the dye, then the inference is this is going to be a urethrovaginal fistula. Clear? So the connection is here, right? So this is going to be a urethrovaginal fistula. Okay. Suppose if the middle one is stained with the dye, then that is going to be a, yes, it is going to be what fistula? Vesicovaginal fistula, bladder under the vagina. Okay, so it is going to be vesicovaginal fistula. And the upper one can either be stained with dye or urine. Okay, suppose let's consider if it is stained with dye. Okay, if it is stained with dye means then it is a cause of vesicovaginal fistula. The connection can also be like this, right? So it can be vesicovaginal fistula, and in this picture they have given a connection with the ureter. Okay, so this is the ureter, and with the ureter there is a connection to the vagina. Okay, so that time the swab will be stained only with urine. Okay, so in that time it will be, yes, urethrovaginal fistula. Clear? I hope you would have understood. Right. Now, let's discuss about the other investigations given to a case of fistula. Okay. So, what are the other investigations? Other investigations include offering a cystoscopy, cysto-urethroskopy, then a retrograde pylography, intravenous urography, urine culture and sensitivity, renal function test, and then you have to also take a biopsy of the fistula site. Okay. So, these are the various other investigations that can be offered, right? And next one is, you have to know how to prevent the occurrence of urinary fistulas, okay, especially while during labor. Okay. So, you should offer them good antenatal care. There should be watchful progress of the labor, trained birth attendants should be there, and you should also have to know about the early recognition of CPD, and you have to prevent the obstructed labor itself. There should be avoidance of destructive procedures or a difficult forceps delivery. You should offer prolonged catheter drainage if suppose an obstructed labor occurs. And finally, for surgical cases, offer adequate exposure during surgery, and dissection should be done in correct planes, and you should do a wide mobilization of bladder. Clear? Right. Now, let's discuss about urethrovaginal fistula and how to prevent its occurrence. Okay. So, urethrovaginal fistula. So, this fistula can occur at the level of infundibulopelvic ligament, at the pelvic brim, so during infundibulum pelvic ligament clamping, okay, that is done during hysterectomy. And the second chance is there is crossing of uterine artery and ureter at the base of broad ligament during ligation of uterine artery. This anatomy you should know, right? It is water under the bridge, that is the ureter under the uterine artery, okay. And then you should be careful while clamping McEnroe ligament as well, where the ureter enters urethric tunnel at the level of, yes, internal os. Clear? And next one is, you should be careful while clamping the lateral vaginal vault, where the ureter enters the bladder during clamping or suturing of the vaginal vault. Okay, so these are the 4 places where you have to be careful while during hysterectomy. One at the level of infundibulopelvic ligament, second point at the crossing of uterine artery, third one while clamping McEnroe ligament, and fourth one while clamping the lateral vaginal vault. Clear? Yes. So, you should always separate the vesico-uterine spaces adequately before applying the uterine stem. So, the dictum that you should follow during hysterectomy is you should identify the ureter along its entire length. Till that, you should cut nothing. Clear? Sometimes you can even offer them preoperative IVP in pelvic pathologies to know the ureter course. Clear? Preoperative stenting can also be given in some cases. Okay. Now, let's see about the management. First one is conservative management. Indications of giving conservative management are when it is a simple fistula, that is less than 2 to 3 centimeter in size, and it is diagnosed within 7 days of the cause, and it is unrelated to carcinoma or radiation. Okay. You should offer them, yes, CBD, that is continuous bladder drainage. This is the conservative management. Okay. This can even be offered for 30 days. Suppose a fistula decreases in size, then you have to give them additional 2 to 3 weeks. Suppose if the fistula shows no improvement, then you have to plan for surgery. Okay. So, continuous bladder drainage is given for 30 days. After 30 days, you are going to review the patient. Suppose if the size of the fistula has reduced, then you can offer CBT for another 2 to 3 weeks. And if there is no improvement, you will take her directly for surgery. Clear? Yes. Next one is surgical management. If the fistula is detected within 24 hours, then you have to do immediate repair. Okay. Otherwise, you can plan for conservative management, and surgical repair is planned only after 3 months. Understood? This is especially in a case of obstructed labor. Clear? So, optimal time to operate a fistula is 3 to 6 months. Okay? Let's see what are the routes of vesicovaginal repair now. Okay, so routes of vesicovaginal fistula repair. Okay, so it can be offered vaginal or else abdominal, and this again depends upon the type of repair. And this again depends upon the type of fistula and also the surgeon's choice. And usually the obstetric fistulas are better dealt through the vaginal route. Clear? Now, let's discuss about the vaginal surgeries available. So, vaginal surgeries include vaginal flap splitting technique, then Sims saucerization technique, and then Latzko's vaginal repair. Okay. If there is a ureteric fistula, you can even do a trans-ureteric enteric anastomosis, that is anastomosis with opposite ureter. You can also give them end-to-end anastomosis, that is done over a urinary catheter, or a urethrovesical anastomosis that can be done with or without bladder mobilization. And finally, you can use bladder flap. Okay, so this technique is known as Bori technique. Clear? Then post-op management. Again, you have to give them continuous bladder drainage with Foley's catheter for at least 10 days and up to 3 weeks also. You can even give them antibiotics and even plenty of oral fluids as well. Okay, and some other additional advice you would give them is avoid coitus for 3 months and avoid pregnancy for 1 year, and in next pregnancy must be an abdominal delivery, that is nothing but a cesarean section in next pregnancy. Clear? I hope you would have understood and this video would have been helpful to understand in detail about the genital fistulas. So until we meet in next video, take care, happy learning, bye bye.